to the Pocatello League of Women Voters Behavioral Health Crisis Centers Forum. The League is a nonpartisan political organization that empowers voters, works to increase understanding of major public issues, and influences public policy through education and advocacy. After thorough studies, the League develops policy positions. League supports affordable, quality behavioral health care, as well as supportive services to treat mental illness and substance abuse. League supports problem solving to avoid entry into the criminal justice system, as well as efforts to decrease stigmatization of behavioral health problems. Tonight, we will focus on behavioral health and learn how it is being addressed in Idaho. Our three speakers are Michelle Osmond, Haley Tyler, and Devere Hunt. They've been assisting individuals struggling with behavioral health issues for a number of years. As program manager for Region 6 Division of Behavioral Health of Idaho Department of Health and Welfare, Michelle Osmond oversees children and adult behavioral health specialists who respond to crisis and court orders, as well as forensic exams to assist the courts with sentencing and provide limited treatment and medication to uninsured Idahoans. Michelle has a master's in counseling, is a licensed clinical counselor, and designated examiner. Last month, Haley Tyler joined the Crisis Center of East Idaho for Bonneville County as director. This center helps adults with behavioral health or substance abuse issues. Haley, a licensed social worker, has worked with migrant teens, homeless men, and at rehabilitative health services in Idaho Falls. At RHS, she had a number of positions, including psychosocial rehabilitation specialist, treatment plan developer, and intake coordinator. And Devere Hunt has a master's in counseling and is the CEO for Rehabilitative Health Services, which provides the staffing contract to the Bonneville County Behavioral Health Crisis Center. RHS provides services such as medication management, counseling, family support services, and substance addiction services. Previously, he worked on the Region 7 ACT team in a joint effort between Department of Health and Welfare and Vocational Rehabilitation. Michelle will lead the panel discussion, and after everyone speaks this evening, we'll have time for questions from the audience. And now, Michelle.
Thanks, Pam. I also want to thank you. I'm remodeling a house, and I have a whiteboard up so that my fiance knows exactly what his job is for the day. And since Pam invited me and to come tonight, I have sheetrock sanding. So I can talk all night if you need to. Actually, I'm excited to talk tonight about the Crisis Center. We have 4 across the state. Well, we have 3 that are up and running, and then we have another one in Region 4, Boise area, that is not yet working as a crisis center. So we have one in Region 7 in Idaho Falls, which was the first one. It opened in December of 14. We have one in Coeur d'Alene that's been open for about a year, a little over a year, and then we have one in Twin Falls that has just been open for a short period. And each one has a little different flavor, and looks a little different, and I think that that's what makes it exciting to have crisis centers in the regions, so they can be region specific and meet the needs that each of those particular regions has. I want to take you down a trip down memory lane. And I have to tell you, we've got the house remodel, we've got this wedding, and now I'm trying to remember what happened in 2008. So I may be making things up. So my administrator's here, she can correct me if I'm wrong. In 2008, for some reason, the sheriff of Bonneville County called me and he said, I've got some money I want to give you. Come over and get it. And I'm like, oh, good, free money. So I went over and he says, this money comes with strings. Yeah, of course it does. You didn't tell me that. And what he said is, I'm going to give you this money and I want you to get individuals out of my jail who are struggling with mental health. And I said, great, we can do that. And so that started us down a path. About that time, Martha Tanner, who is an advocate for mental health treatment in Region 7, has a son who struggles with a thought disorder, a serious thought disorder, and Martha is brilliant. So she gives me a call and she says, I just want to come and talk to you about this new program that NAMI has. It's called CIT, and it will just take a few minutes. And I said, great, come talk to me. She comes in with what looks like carry-on luggage, plus her purse, and I think, oh no, we're going to need more than 45 minutes. But she brought the CIT program up, and we started to look at that, and Captain Sam Holtz became involved from Bonneville County, and the stars were aligned, and we did the first CIT training in the state in 2009. And we use the Memphis model, which is 40 hours of training for law enforcement and first responders. And the one piece that we didn't have was housing. So the Memphis model has the University of Memphis right there, and they have about 600,000 more people in Memphis than they did in Idaho Falls. So they had some resources that we didn't have. And so we started looking for, where do we find this housing piece? If they don't need to go to jail, if they don't need to be hospitalized, why would we do that to someone? And so we started a search. And some folks from Boise, our central office, visited the Billings Crisis Center in Montana. And then a group of us went several months later to see how their model worked. And that's where we started, was from that model of, this is what it looks like, here's what we want, and now we've got something that is somewhat similar and somewhat very different in all of our different crisis centers. So we finally had that last piece we needed for law enforcement. In Region 6, in the last 10 months, we've done 204 designated examinations. And what those are orders to meet with people about harm to self, harm to others, or gravely disabled because of a mental illness. And they take them into the hospital, and they start this court process, and they're admitted to the behavioral health unit, and then the regional staff go in and do this exam. Let's see, about 20% of those 39 people were actually committed to the Department of Health and Welfare. So we had 80% that went to the hospital because we didn't have a safe place to take them, and they couldn't be safe on their own, and so they ended up either being admitted to the hospital unnecessarily with a large bill, or they ended up in jail when we could have actually given them some treatment somewhere and avoided the whole jail issue. And when we stop that at the jail, what really happens is we can make a big difference with folks. If we can get them the right treatment, then we don't see them back. We have lots of specialty courts in Region 6 and specifically in Bannock County. And we can get folks the help they need and the treatment they need, but we got to keep them out of jail and we got to keep them out of the hospital. Our division administrator talked with the governor about crisis centers and about mental health and about the piece that we were missing in the treatment continuum, and that was housing, crisis housing. Where do we put folks? And the governor liked it, and he talked about it, and he gave us some money for it. And so the first crisis center, the one in Idaho Falls, they had we called it the steering committee. We had a group of folks in the community who were committed to getting a crisis center set up there, and they responded to the RFP that the state put out for this money. And Coeur d'Alene did the same thing. Only our legislators in Region 7 were more supportive of the concept, and that's why Region 7 got the first one. The next year, Region 1 did. And it was all about the legislative support that they needed to get that there. And it sounds like we've got some legislative support with Senator Nye, so we love that. Thank you. And what the funds were $200,000 one-time initial startup funds. And then there is $1.5 million a year in general state funds to go with that. After 2 years of being up and running, a plan for sustainability of $750,000 non-state funds with the match of $750,000 of state funds needs to be submitted. Now, when we talked with Ross this afternoon about that, it was suggested that we put a plan in for 15 years. We will take state funds for 15 years, and then we'll figure it out. And he said, no, that won't work. And we said 3, and he said, yeah, that's not going to work either. So really, it's not 2 years that we have to be self-sustaining. It's 2 years that we have to have a plan of sustainability. That's what Ross sold to the legislature. That's what the legislature approved for us. So now we have 3 centers, and he only asked for 2, and we're looking at plans of sustainability. What he told me is, Michelle, if your community wants a crisis center, you need sustainability from the get-go. You come to us with half of that $1.5 million, and we will. He goes, I'll make it happen for you. We'll get the money. So we need to be looking at who are our community partners. One of the things that had worked well in Montana was they did a bond. And part of the bond went to support the crisis center. And that is ongoing. And that might be something that the community wants to look at. There's grants and soft funding, but it's pretty hard to budget on soft funding all the time. So really what we need with our plan moving forward is, here's what we've got, here are our community partners. One of the in-kind savings that is huge in Region 1 is the building is on the hospital campus at Kootenai. And Kootenai is a community or a county hospital, so it's government. That's part of what needs to be in the grant. It does need to be a government entity. So our hospital here, Charlie, is private, correct?
Partnership with community. Sean's over there. We'll give you real detail. It is private, yeah. It is private.
Well, Sean, I've got sanding going on, so I've got lots of time afterwards to hear how that works.
So you need to repeat what they said.
Oh, okay, I'm sorry. I asked Charlie to confirm that the behavioral health services at Portneuf was private, and then he referred us to Sean with Portneuf Trust, who agreed that, yes, it was a private institution.
So,
Stephen.
do I understand it correctly then the money from the state has to go to a public entity?
Yes,
Start with?
in that grant.
So,
Oh, so, I'm new to this. You put an Osmond in front of a microphone, and she doesn't know what to do with it. So Stephen Wigg asked if the contract needed to go to a government entity, and it is my understanding that it does have to go to some type of government entity. So if it's a county hospital, that worked in Region 1. Bonneville County is the fiscal agent in Region 7, so that worked. Public Health, I believe, is in Region 5 as the fiscal agent. So we have to look at some of those things that are in the proposal and in the rules to comply with, but they're not insurmountable at all. So when I talked with Kootenai, because they are on the hospital campus, it is fairly convenient to them. If someone presents at the ER, to walk them across the parking lot and let them be at the crisis center. Now, they may do some testing to make sure that there's some medical stability, but they also have nurses who are staffed by Kootenai Hospital who can also do that assessment. So the path goes both ways. They come into the crisis center, they may be too much. For the crisis center, they may need some medical oversight, so they go over to the ED, and then the ED brings them back. But one of the things that they've been able to do with that is say the average amount of money for a 24-hour stay for someone who is indigent in the ED is $24,000. And so they've come up with $1.7 to $2 million savings that the hospital has seen over the past year. And 1.7 is the conservative. Don believes that it's more of a $2 million savings. The other savings that we see with crisis centers is with public safety. The sheriff's department may save no money because they're paying the same amount of deputies to be working at one time, but what they're saving is man hours. Every mental health call lasts about 4 hours average. Isn't that right, Sheriff? Yes, so the sheriffs agree that at least 4 to 5 hours at a minimum for a mental health call that his deputies are tied up with. But if we have a crisis center that they can take them to, that care can be given, problem solving can be given, they can be safe, we just freed up one deputy's time. And sometimes it takes 2 deputies because sometimes our mental health folks aren't as compliant as we'd hope when we go out. So it really does impact public safety from that perspective. And then did I mention that one of the in-kind things that they do in Region 1, because the crisis center is part of the hospital, they don't pay any lease, which is huge. I believe that they currently in Region 7 lease the building that they're in from Bonneville County. Bonneville County purchased the building and renovated it with the initial $200,000, and then they pay rent every month on that building. So that's a huge cost savings to have an in-kind partner that says, we'll let you be here, but you don't have to pay us any rent. So those are the kinds of things that will make a crisis center successful. The money is there if we put our plan together for sustainability, and we do have a group, I believe, that can do that here tonight. So I will turn the time over to Haley. She's going to talk to Devere. Okay. You're going to talk about some of, you threw me, Haley.
So
we're next.
I'm so sorry.
Devere will talk about some of the challenges that they've had as the service provider for the Crisis Center and some of the things that we thought would work. Devere was involved from the start. He was part of that steering committee that we had when we were trying to figure out what we wanted. And so he can talk a little bit about where we thought we were starting and where we finally ended up.
So I will speak a little bit. When we were on the steering committee, at the time we didn't really understand or know the structure of how it would roll out. There was none in the state at the time. So we kicked around a lot of different ideas how that would eventually roll out. So I'm going to tell you how it rolled out in the end, and then explain how that changed from the beginning. In the end, with a government entity, Bonneville County received the contract with the state, and so there's multiple levels of responsibility. The state has the contract with the county, so the county has all the obligations to report back to the state everything that's going on in regards to sustainability, in regards to plan, implementation, services, etc. The county is the government entity that has to respond to whatever is inside of the contract with the state. So how that works is the county, and we divided this up through our steering committee as we evaluated numerous ideas, and so there is the security piece to the facility, there's also the professional staffing piece to the facility, and then there was the administration part of the facility. In the beginning, what the county had done to start with is they hired a county employee to be the director of that facility, which I think was probably the only way to get that up and running. Part of the reason I believe we got the contract in our area as the steering committee is we said we could have this up in 60 days. That was my idea. I don't know if that was a great idea, but that was my idea. And so I helped write that whole piece of implementation, et cetera. And so we did get it up and going in 60 days. We were probably, I think, 67 days beyond that, or 67 days total, because the facility wasn't quite ready yet. So what we did with that is they had the county employee that really started running with getting the building ready, managing the facilities, worked a ton with Tracy Sessions at State Hospital South in-kind donations with beds, and State Hospital South and Tracy, who everybody knows Tracy, let it be known that I'm in Idaho because of Tracy. She was my first employer when I moved from Utah State with my master's degree 23 years ago. Can you believe it's been that long? Tracy helped me to understand I talked too much, and my wife continues to tell me that. So thank you. That was my first evaluation with Tracy. Veer, you have a lot to say. It's good stuff. Say it in less time. So I'm still working on that. Haley can attest to that. So we had the administrator over the facility was Brenda Price at the time, and she was a county employee. So then we split the services out as far as the staffing contract. So all the staff in the facility, which at the time were RNs, psych techs, master's level clinician, what are we missing?
Case management?
Case management, sorry. And a case manager. So it had RNs, case managers with a 4-year degree. Our psych techs were like you might find in a hospital, either at Portneuf or at BHC or State South. And then we had the law enforcement, which was not part of that staffing contract. So the staffing contract, which RHS has, was to provide the professional staff in the building. So we were the clinical ideas, the clinical piece of standing up the facility. Brenda, the county employee, was the fiscal agent setting up the facility. And then Sam Holtz, who Michelle had already mentioned, represented from the county. And so all of our security in the facility are county employees, law enforcement. And we've moved in a different direction with that to some degree. It was originally law enforcement that were active duty law enforcement. In regards to sustainability, Sam has done a great job looking for retired law enforcement. And so we actually employ law enforcement out of Madison County, Jefferson County, Bingham County, and Bonneville County. Some of those are retired, some of those still work for those counties. And they are in the facility as the security contract. So we brought all of that together and stood it up without a lot of ideas. Well, we had a lot of ideas. We didn't have a lot of know-how on which ideas were going to work the best. How our county works it, a lot of our original individuals coming to the crisis center really was a heavy piece of law enforcement, and we expected that. We expected a high level of law enforcement. The main reason, the concept behind the facilities in the very beginning, from Ross Edmonds, from the governor, was to reduce the expenditures that we spend in EDs and in jails. Law enforcement in the past, as your captain can probably attest to, you have an individual that might be suffering from a mental break, they might be intoxicated, they're public, and there's really nowhere to go with them, there's nothing to do with them, so we're going to take them to the ER, or we're going to charge them with kind of a petty crime to get them into the jail to get them safe for the evening. So the entire goal of these facilities was multiple pieces. One was the fiscal aspects of that, to save the money in the jails, to save the money of law enforcement, and to save the time in our ERs. And the other side of that, which we look at as the clinical side of things, is it is such a better place for us to be able to work with and treat them in a facility where we can address the issues that have law enforcement at the door, where we can address the issues why there's a psychotic break that we're dealing with at the time. So we can address them from a clinical approach versus a medical or a law enforcement approach. And the goal is not to just, if you go into an ER, that you take care of what's in front of you and you send them back out. If you're dealing with law enforcement, you go into the jail, you have a crime, you pay your fines, you pay your fees, you might have probation, and it clogs all them up. But you're not addressing the reason. You're addressing the symptomology instead of addressing the illness or the addiction. And so as they land in the crisis center, we're able to start looking at what is creating the addiction, what is behind the illness, and how can we start providing them into treatment and get them into a path where in the future they don't need the crisis center. possibly, but for sure we can reduce the jail and we can reduce the ER visits. And so it's a humane way to save money, which we always as a state, we're a conservative state in Idaho. We respect the public dollar, and this is a way to save those public funds, but not just save them, but to provide compassionate treatment and a plan and a future for individuals that are getting lost inside of that system. That's the whole thought process behind it. I can speak more to what we do in the facility. I'm not sure exactly what information you're looking for, so I can go any direction. I can talk, right, Tracy? I can talk. I can speak to the facility and our typical. I'll go if they have a question.
How many beds are in your facility?
Okay, so the question being, how many beds are in our facility? We have 20 beds in the facility. That was delineated by the contract. There are 10 female beds and 10 male beds. What we have in our facility, and they took an old restaurant, and let it be known that Bonneville County took the $200 and more than doubled that in investment into this facility. Bonneville County has stood up strong. The building itself, I think, was $415,000 unmodeled. So they remodeled it, etc. So they have a huge investment, which is where the lease comes in to help pay them back for their upfront investment. So the stipulation comes out of the contract that the county has with the state. What we have is we have 2 large rooms. One is a female room, one is a male room, and then we have 2 comfort rooms that are individual rooms with an individual bed, which helps out for various issues, whether there's a medical issue on hand, whether there's an individual that is having social detox that might be very inebriated that we're a little more concerned about. Some of the pieces that have fallen into that we didn't really even expect is we have a transgender population that we've had to work with that population in trying to figure out where do they fit in. And so if at all possible, we try to put them into one of the comfort rooms to give them some privacy, but also to respect the personal interests of all other individuals as well. And so that's how many beds we have currently.
So given that, what's your average daily census? How many people per day are you seeing? What's the mix in terms of substance abuse and mental health?
Okay, so the question being, what is our mix between substance abuse and mental health, as well as what is our average number of individuals? And Haley probably has that information, and so I'll let her answer that.
So our average daily census right now is about 6.6 people per day. That's dropped. We do reports every quarter for the state, and the last quarter was 9.5. We believe the change in the census is due to the really cold winter that we had. We were definitely housing a lot more people overnight because of the cold. And then I'm sorry, what was your second question?
What's the mix in terms of substance use disorder, behavioral mental health, or combination kind of thing?
Over 60% is both. Oh, I'm sorry. The question was mental health versus substance abuse, the population. About 60% is struggle with both substance abuse and mental health. As far as substance abuse alone or mental health alone, they're about even.
One of the things that I'll just follow up with that statement likewise is, so they kind of come in rushes, and so an average number is a little bit deceptive sometimes, because we've had up to 15 in the building at any given time, and then you might have a day or two that the sun is out and everything's bright and great, and if you're drunk, you're on the river enjoying yourself, and you're not having any problems, and there are cycles and there are themes, interestingly enough, that we have in the facility. Like one week we might have all just meth use with some substance. Another week we might have psychotic disorders. And so it's really interesting how there tends to be a theme. But the average is it's a little bit skewed in my opinion, because from a law enforcement perspective, if you have 15 in a facility one day versus 2 on another day, well, that 2 days a really good day for them. Okay. And so I just wanted to point that out, that goes all over the place.
Sheriff.
While we're talking about statistics, what is the gender? Is it male or female? Higher or lower? And there's a method in my madness because of that. So
Okay, so the question was regarding
gender of those that are coming in.
the gender of who comes in.
Both, which means self-medication and those type of things that we would refer to with mental health. But gender, do we have more women?
We currently have more men than women, not by much. And interestingly enough, I was reading a report out of Montana this afternoon, and Montana sees 60% women, over 40% men. Ours is not quite the same. We see more men than we do women, but it's very close. It's within 50s.
If I remember the last report I saw was
I
like
can find-
58 to 42%, 58% men, 42% women. And Haley's been in her position for about 6 weeks and is doing an amazing job. And so if she doesn't have them right off the top of her head,
I can
it's
get
because she is already, she's just done an amazing job for us. So we're excited to have her. So, another question?
How do you determine whether a person's having a true mental health crisis versus they just need a place to stay?
Okay. So the question being, how do we determine a true mental health crisis versus just a place to stay? So as I've been working with my staff, we've been evaluating our admissions policies, we've been evaluating our discharge policies, and so kind of what I felt like my staff was falling into just a little bit is they were asking, well, why are you here? Why are you homeless, or what's going on? And I felt like we needed to elevate our questions from the perspective that, okay, do you have a mental illness, or are you just going through a tough time? And we tend to look at it more that, is it a crisis to that individual? Because that individual, if they're homeless, then the question isn't, are you homeless? It's what has led up to your homelessness? What has created this scenario in your life at this time? So we really want to find out a little bit more about what is going on instead of just looking at them and going, okay, your mental illness, or your substance abuse, or you're kind of this catch, we're not sure what you are. And so the advantage of that is that we do have case managers in the building that are all 4-year social service mental health providers that have been working in the field for a period of time that have seen those experiential pieces. Your professional has an ability to really look at that. Now, there's also assessments that we complete in the facility. The first assessment that happens is a nursing assessment where they'll evaluate medical stability, identify whether they need to be taken to an ED or an ER, or whether we can manage them in the facility with their current issues. We have on the board, we have Dr. Keller used to be on the board, who works with Badger Medical, who runs all the facilities from, he has, I think, the entire southeastern side of the state for medical services in the jails. And he gave us the idea that if they're walking and talking, then you can keep them. And so if they're beyond that, then we will send them to the ER for maybe some medical detox or something that way. But it really comes down to that professional in the building to evaluate, ask the right questions, have the right experience and the right training to evaluate what the needs are of that individual. Hope I didn't go too far to answer that question.
Can I just one more question? So have you ever denied anyone?
We have denied individuals, and for various reasons. We've had some individuals that it's not that we would deny them, but we send them to the ED for stabilization, and then they come back. We've had other individuals, and if you're going to say deny, I think the individuals that would be denied are individuals that maybe take advantage of the system. That we had one gentleman, for example, he was on Social Security benefits, and he felt like he wanted to come in and just kind of stay. He'd get his benefits, go buy guitars, all kinds of things, and then come stay at the facility. And the facility has a 23-hour, 59-minute rule to it. And that's really in place due to Idaho housing rules in regards to residential treatment, residential facilities. And so we do have to discharge in that time frame. And if we evaluate that discharging them, we look at them to readmit almost immediately sometimes. But we do have to make sure that we're managing that discharge piece of that. But the denial would be as if you have an individual that just is not moving forward, they're not working on it, they're not trying to improve the situation. We also, there's two populations that we have found are a greater population in our community than we expect, and that is dementia and developmental delayed population. And so and law enforcement can speak to, I see him nodding back there, that it's a population, especially the dementia. You'll see the not Amber Alerts, I hope not, but you'll see the alerts that go out over TVs, et cetera, that, hey, Johnny, 84 years old with dementia, has gone missing. He's been gone for 6 hours. Well, our law enforcement are the ones out there finding them, picking them up, et cetera. And so it's a population that the state at some point is going to have to manage, because we are an aging population. It's what they call the failure of medical success, that people live a lot longer. And so so those individuals, dementia does not fall under the catchment of behavioral health. Also, you have a lot of a developmental delay population, that if they're not determined disabled or developmentally delayed before age 23, then they really don't fit in anywhere. So we've had numerous of those individuals that come in, maybe they're 32, and they really need developmentally delayed services versus mental health services. And so we help them to identify if you can go back and find a school IEP, or if you can find out where they were diagnosed prior to that developmental health population. We're kind of serving because there's really not another place for them to serve. And that developmental health population also, they'll feel suicidal, they experience depression, etc. So it's kind of a coexisting diagnosis when you have the developmental health and the mental health. Did that answer your question? Yeah. Okay. Tracy, you had another question.
I was just going to suggest that you talk about not everybody stays overnight.
Okay.
Some people come in for 4 hours or 6 hours.
Okay. So the point being, how long do they stay in the facility, or do they stay overnight, et cetera? And so as they come into the facility, we start tracking immediately that 23-hour, 59-minute stay. If they come in at 2 p.m. on Tuesday, we have to know what's going on with them by 1:59 on Wednesday. Now, we also track our average stay, and our average stay, I think, is at 13 hours or 14 hours?
16.5 hours.
16.5 hours, the average stay. Now, just like Tracy said, we have individuals that might be there for 2 hours. I was there 2 weeks ago. We had Idaho Falls law enforcement brought in an individual. He had just been released from the jail that morning. He had been in the ER already. He needed some medications for anxiety and Valium, and he got picked up by law enforcement because he was knocking on neighbors' doors, pretty unaware of himself and not sure what was going on. Idaho Falls Police Department brought him to the facility. They were there about 30 minutes, 20 to 30 minutes, and then they were gone, which is a little bit better than 4 to 5 hours. He was in our facility. We did an evaluation of him medically. We had to chase down where he had filled some medications. He was a very poor report. He wasn't sure exactly what was going on. He was there about 2 hours before his girlfriend came and picked him up. Law enforcement picking him up, knocking doors in the community, well, they're going to either charge him with a crime for trespass or for public intoxication or something, or they're going to take him back to the ER where he was in the morning, and he was in jail that morning likewise. And so just that individual being in our facility for 2 hours, waiting for his girlfriend to come in and help him out, to take him home, it saved all those funds that could have either been in the jail, and it's not just going to the jail, because once there's a crime filed, now you're in the court system. And so we're not just clogging up jail beds, we're also clogging up the court system. And in the court system, then you have choices there that, well, do we go to probation? And so it's hard to determine how much money you save on someone that you don't know where they went, right? And so you have to make guesstimations on that. But that was an individual there 2 hours. We were there this morning. We had an individual just extreme anxiety. And this is how law enforcement works. We had Idaho Falls Police brought her in. She believed that somebody had injected her with something. She didn't know what it was. She wanted to go to the hospital because she was afraid for her life. She was only in the facility about 45 minutes, and then she left. So our law enforcement officer contacted Idaho Falls Police Department and said, hey, she just left. This is where we saw her last. And so there's a communication going on there. So she was what we call a non-episode. We did not officially admit her into the facility. But so we document that and we track them on what's going on. And so it's not just even individuals that even get checked in. We have a ton of people that come to the facility and they just are looking for education or looking for information. You guys have heard there's a lot of community providers that provide case management or psychosocial rehabilitation, or it's CBRS, community-based rehabilitation services. Brenda will correct me as I say that correctly. Brenda, who is from our representative from Optum, is here, who we have many individuals that the crisis center becomes part of their treatment plan and part of their crisis plan. And so they receive services in the community through a Medicaid benefit that is through a managed care company, which is Optum, which is the managed care company for the state of Idaho. And so what many of our individual workers do with those clients that are somewhat stable is they will develop a crisis plan with them. In the past, if we had these individuals that were dealing with anxiety, suicidality, maybe some intoxication, substance abuse issues, the only place to take them was to the ER. So they have a CBRS worker, a trained bachelor's level professional to work with them in the community, but they only have X number of hours they can work with them on. And you can't resolve a crisis immediately all the time. So the answer was to go to the ERs. And I'm sure your ERs here have experienced many of these situations. And so what a lot of our community providers will do is they will bring the client to the facility and say, if you're in crisis, if you're feeling suicidal, if you're feeling unsafe, then instead of going to the ER, let's come to this facility. You can stay a couple of hours, you can stay 20 hours. You can do whatever you need to do so that you're not in the ER, but you're in a place that feels safe. And so not only is it a place that they can come to feel safe, but now it becomes part of their treatment for stabilization in the community that they go, okay, if I'm having a bad day, I know I can go to the crisis center. And I'm not going to get probed and prodded. Medicaid isn't going to get a huge bill because I sat in the ER for 6 hours today, okay? I'm not going to have to give blood. I'm not going to have to do all those things. I can go to a safe place. I can receive some empathetic treatment. And then when I feel a little bit better, then I can go home.
I have a couple of questions.
Tracy, did that answer your question? Was that kind of what you're speaking of? Okay, sorry.
So, can any of the staff within the crisis center bill Medicaid for the services delivered while someone's in the crisis center?
Okay. So Michelle spoke to so the question is, can anybody in the facility bill for services in that facility? Okay. Michelle spoke to the idea of sustainability. They want us to get to a 50% sustainability. In all the crisis centers that I'm aware of across the state, currently it is a free service to anybody that needs that service. One of the things, because we are the pilot project, we're a little bit ahead. Coeur d'Alene opened 2 years after us, and so we've already started the sustainability piece. In January of this year, we were reduced by 10% the funding from the legislature, from health and welfare. We're supposed to reduce another 10% by next January. It would take us to 80% as we're on that way. So one of the things that we're evaluating is, can we bill for services inside of that facility? And so there's numerous services that we're evaluating you can bill. You can bill some case management services. You can probably bill some medical assessments. You can bill for social detox. And you're also looking at a large array of funding providers. Some of those services might be funded through Medicaid Optum, which is the mental health side. The nursing assessment may be funded through Molina, which is the medical side of Medicaid. The social detox can be funded by Blue Cross. It might be funded by BPA. And so we're evaluating all of those kinds of things. Now, one thing in the facility, statistics, we are tracking the number of individuals that have what types of insurance versus those that are an indigent population with no insurances. It's also important to realize as you track the indigent population, your local counties are the ones that pick up those bills in the ERs for the indigent piece. And so we're really trying to identify who is saving the money for the services that are being provided. Because when it comes to sustainability, we need to go out and say, look, as a county, you're saving this much of indigent funds, or as Blue Cross, we're doing social detox here versus medical detox at ERMAC or at Portneuf. You might go to Optum and you look at what case management services. Now, some of those things in regards to the billable piece, we've got to look at our legislatures to find out what can be billed in a facility. Now, your legislators are also going to say, well, now you're talking about a cost shift, okay? So we have health and welfare giving you money on this side. Well, health and welfare also funds Medicaid. And so anybody that has any level of intelligence, which most all of them do, are going to go, okay, how do you explain that cost shift? Are we reducing it, or are we just experiencing a change in how it's billed? So, does that answer your question?
So over a 24-hour period, what's your base staffing? If I want in there at 8 in the morning or 4 in the afternoon or 11 o'clock at night, what's the core number of people that are in that facility? And I assume it varies by census a little bit.
Okay.
Is that correct?
We have not modified it by census yet, okay? When we start hitting 12, we have 20 beds. When you hit 12, 13, 14, it gets real interesting. To say the least. It can become very interesting. And so that's where we are evaluating census on that side. But what you have in the facility, you have a medical professional there 24/7, 365. Interestingly enough, when you look at the contract, it ensures that it talks about leap year. It says 365 and 366 on leap year. So just to reiterate the contract. So you have a medical professional in there, which originally was defined as an RN. The steering committee, we bounced around a lot of different ideas. Medically, what do we need in that facility? What needs to be completed? We evaluated the ideas of LPNs. We looked at RNs. We even talked about CNAs or MAs, et cetera. We decided at the time, Kim Jardine, who many of you may know, is a huge advocate of mental health, and she felt very strongly about that we needed RNs in that facility for their experience and their expertise. We have found, and if you look at any national statistics across the country, RNs are a premium in our country, and they're a premium in our state. And we have had a lot of difficulty trying to fill 24/7 RNs in our facility. We've been paying OT for nurses. We're doing 60-hour weeks on some of these individual nurses, et cetera, which, then you're looking at exhaustion with staff and those kinds of things. And so I sat down with the previous director, and we thought about what other medical professional can we utilize. And so we are currently right now, we modified our contract with the state to identify as a medical professional versus a registered licensed nurse. And so we just hired 3 paramedics. And so we're right now rolling them in. We should have our first paramedic training actually this Thursday. We love the idea of the paramedic because they're triaging this out in the community all the time. They see mental health every day. They see intoxication every day. They see the medical issues every day. And they have a very similar training to the nurses for the piece that the nurse provides in our facility. And so that's a piece that we're looking at there. So we do have a medical professional in the facility 24/7. We have a psych tech in the facility 24/7. We have law enforcement or security in the building 24/7 likewise. And then we have case managers in the building from 7 a.m. to 9:30 p.m. And the reason we selected those shifts is the case managers are primarily working with ancillary services in the community, where they're reaching out and trying to find housing. They're reaching out and trying to find a detox center. They're trying to find a medical facility for the patient to go get some help with their high blood pressure medicine or something that way. So we've identified that it's much easier to reach those offices when they're open. For some reason, they don't answer the call when they're closed. And so we staff them during that time frame, and there's a double coverage in the afternoon. They come on, so our first shift comes on at 7, and she stays till 3:30. Our second CM comes in at 1, and they stay till 9:30. And so we have about a 2.5-hour gap where we have 2 case managers in the building, which conveniently corresponds with when we seem to have a lot of people in the building. So.
You mentioned clinicians earlier.
Yes, so
Are they in the building every day?
So they're not in the building every day. So anytime you're in mental health, your bachelor's level staff need to have supervision by a master's level clinician. It's that way with Optum. It's that way across the board that you need that supervision. And so we provide the clinical supervision. It's an individual from my office that's a therapist, master's level clinician that comes in, and they do a staffing once a week where they evaluate different scenarios that have happened in the building. They do a level of education to that facility. Now, originally, we set aside, I think it was like 600 hours annually to have a clinician in the facility, which a lot of our numbers in the beginning were just guesstimations, and those 600 hours are nowhere near utilized. We use typically anywhere from 3 to 8 hours a month in clinician time. And so that's for if we have a specific situation where they might need to contact somebody. I do a lot of the individual things that just show up on a day-to-day basis, and then I have a clinician that comes in on a weekly basis to do that training.
One last question for now. Is $1.5 million per year enough?
$1.5 million per year. So I can tell you we've reduced by 10%. And we're doing fine right now with that, okay? I think the 1.5 million is sufficient for what is required. It is our goal to reduce that. I don't want to throw out numbers because people write those numbers down, and so I'm going to say that I think that from an efficient perspective, we are working on learning how to function on less than that amount. The obvious goal for Ross Edmonds and for the legislator is for us to reach at either $750,000 state funding or a level that can be sustained by the community. I believe personally that this is DeVere Hunt, nobody else. So I believe that we can sustain ourselves on less than 1.5. I believe that we can sustain ourselves on probably 1.1-ish, 1.1 to 1.2, which means two things have to happen. Either you've got to have buy-in from your community, okay, that are going to contribute, or we look at the crisis center similar to how they did the Wood Project years ago, which was a pilot project. It was not a line item issue on the budget for the legislature. I truly believe that 50% sustainability is going to be extremely difficult to get to. I don't see how a community can just come up with $750,000 to make that difference. Now, I believe that a community can come up with funds, but I honestly think, but we're doing everything we can to get to that 50%. I believe that there is going to have to be some discussion at the table that maybe the state is at 62% or 65%. Once again, that's just DeVere talking. That's not Ross. That's not the legislature. That's just 3 years' experience in what we're seeing.
So, since you've been operating 2 years, and you've talked about cost savings to law enforcement, the county, and the hospital, have any of those entities stepped up with a significant financial contribution to offset the loss of state funding?
So currently, Bonneville County, I will sing their praise. They have invested much. I know that Bonneville County operates on a loss with the security. I can't remember if it's a 10% loss or a 20% loss. They operate on a 20% loss to provide that law enforcement in the building. So is it money they're giving us? No, but it's an identified amount of that 20%. It's really difficult. Important enough might be able to speak to this. We have an advisory board. Every region is required to have an advisory board. Excuse me. And we have representation from Eastern Idaho Medical Center, Regional Medical Center, which is the BHC division. It's difficult to go to a hospital and say, we saved you $100,000, why don't you give that to us? We have not seen any funds from them just yet. We are at the point right now that we're starting to look at that community contribution. We've got to come up with real numbers. We've got to be able to realistically identify and say, look, we're saving you this much money in your lost funding, okay? Sure, you're not going to give us $100,000. If you saved $100,000, are you willing to give us 60? Are you willing to give us 50? Some of those kinds of things. So that is where we are currently with the facility in regards to sustainability, is we are now starting to have those discussions where now we've got some time behind us that we can come in and evaluate and say, okay, this is our numbers. This is what we're seeing. Another place that we're looking at is all the other counties. Obviously, Bonneville County has contributed significantly. Our facility has a catchment of 17 counties, which includes your counties here, and we have residents from your facility, from your counties in our building. And so our goal is to go back to some of those counties and we can say, look, we've had 42 of your individuals come into our facilities, and that would translate back into your law enforcement or back into your county coffers or back into your indigent funds, etc. And so those are the things that we're really trying to look at right now. That's not a great answer, but that's probably the only answer I can give you right now.
And that's one of the lessons we've learned as we've gone through, is that we didn't have those discussions from the get-go. We talked to the community partners. Yes, we're going to save you money. That sounds great. But we didn't have formal agreements that said, this is what we will contribute on an ongoing basis, a percentage of what we save you. And those conversations didn't happen. And they need to happen before we start saying, okay, we're going to save this money, and then maybe Sheriff Nielsen won't buy a new patrol car. He'll give us that money. Because where's the fire? It's probably in his patrol car and not the crisis center at that moment.
And you guys are at a huge advantage versus where we were, because you can look at us, you can look at other facilities, and you can say, it worked. You know, what they did worked. It's worth the investment. And what Michelle is speaking of is up front, you can say, look, we anticipate this kind of piece. We're going to partner with you up front. The problem we're finding just a little bit right now is we're there. And from their perspective, you're doing a great job. Really appreciate it. They don't have to be as vested into it as maybe your community does to try to get a facility. So you guys have an advantage right there where you can really truly partner, where we did not have any of those firm numbers. And so I appreciate you bringing that up. We did not have those firm numbers and those firm partnerships in place. Oh, I'm sorry, we'll go here first. John, I don't know.
Yeah, just a quick question. It would seem to me that it would be critical. Well, first of all, it'd be easy for you to have a partnership with a hospital, because the hospital has somebody come in and they would all see that they need your services, and so they would discharge them. And it would seem like that would be a pretty seamless partnership. But it would seem harder to me to sort of get into the culture of the criminal justice system, all the way from the law enforcement heads to the rank and file police departments, and then back to prosecuting attorneys, judges, and trying to figure out how you work with those folks to really get not only both the cost savings, but the savings from a human perspective that you described when you very first started, saying just getting them in the right place to get them in the right frame of mind, or get them the help they need in the right circumstances is important. How is that working? And are you hopeful for the future? What opportunities are there?
So the question, just to summarize, is how are we communicating and working with law enforcement, the court system, et cetera, in regards to the humanistic side as well as the financial side of that partnership? Okay. And I appreciate that question, and that's a great question. The number one provider in the United States of mental health services are the jails. Straight up. Jails provide more mental health services, and the prisons provide more mental health services across the country than probably any other individual entity. And so most of your law enforcement, from your jailer up to your prosecuting attorney, recognize and see the mental health population in front of them. I can speak towards Bonneville County. As Michelle spoke earlier, we have a very progressive county in regards to CIT officers being trained and really caring about the humanistic side of mental health as well as addictions. And so I can speak kind of on two sides of that. Bonneville County, on our advisory board, our chairman of our advisory board is Bonneville County's lead prosecuting attorney. And our vice chair is Sam Holtz, who is the captain of Bonneville County's law enforcement. And so we have an amazing relationship with law enforcement and the court systems, and we have a wonderful buy-in from them, not just from a financial side, but from a humanistic side. So I think we're extremely fortunate. Another individual on our advisory board is Steve Hunt, and he represents Idaho Falls Police Department. Idaho Falls and the city of Idaho Falls, and I'm going to speak, I haven't spoken with the mayor, but I've heard her approach. They have not contributed to the facility to a great extent. The reason they feel, and this is where you guys have an advantage over what we had, is they feel like from the mayor and from the city council that this is a state-funded facility, and the state is the one that put it into our community, and they don't feel it is fair treatment. And once again, I'm not speaking for them, I'm speaking for what I've heard, and I can understand their perspective is you brought a state entity to our community, and now you're telling us to pay for it. Okay? From a governmental perspective, when you look at all the different financial coffers, a city councilman and a mayor is going to say, you brought this to our facility and thank you, it's great, but now you're telling us to pay for it. okay? And in our county, I mean, our city has taken a pretty strong approach to go to the state, go to your legislature, and get them to pay for what they put in our community, okay? Because it's all about tax representation. That if they're paying tax dollars towards something that their patrons didn't vote for as a city expense, then should they spend the money on that? That's a reasonable argument, okay? Now, sitting in the crisis center, I sure wish they'd chip in. And so I hope that there are state or city representatives here, and I hope that there are city councilmen here, because our city, Idaho Falls Police Department, probably received more financial advantage to this crisis center being inside of our city than our Bonneville County does, or Jefferson, or Bingham, or Jefferson County. And Steve Hunt does a great job, and he's always at the table offering what he's able to offer. So I tend to talk a lot, so I don't know if that's answering your question.
So I'd just like to relate a short story about when we started the crisis center, or when we started CIT and then moved to the crisis center. Sam Holtz, Captain Holtz of Bonneville County, sent me an email, and it said, it was from one of his deputies. It said, "Captain Holtz, I don't understand all this touchy-feely stuff, but it seems to be working." And that has continued. I think once we teach new skills, and we have an active CIT training program here in Bannock County. I believe our next training is set for November. Really helps that continuum of care from the police and understanding. The very first CIT we taught, my whole front row was the hostage rescue team. They did not want to know about touchy-feely stuff at all. Every time we asked a question, they thought we should use a flash, what is it called?
Flash grenade.
Flash grenade. I don't even know what it is. And then by the time we got done, I'm seeing the emails of, it really works.
So a quick follow-up, do you have an estimate of how many people are still incarcerated in Bonneville County that probably shouldn't be? I mean, that's a tough question, but if you have the right scope of services, if you have a broader scope of services or a dream scope of services, are there still a lot of people in Bonneville County that are incarcerated that could use mental health services?
So the question is, how many people in Bonneville County still need mental health services if we had whatever we wanted? And I would redirect that question to Sheriff Nielsen and say, how many do you have in your jail, Sheriff, that could use mental health treatment?
We don't have in Bonneville County's jail?
No, your jail. How many have you transferred to Bonneville County? No, your jail. Let's talk about right here.
I can give you exact numbers. We do hire a mental health clinician. We're required to do that. And she is extremely busy. Since I'm standing up, I'll take this opportunity to tell you that it's a shame on society that jails are the ones that do this. You don't have diabetics that do this. I have to shackle and handcuff somebody to transport them. They'll tell me not to do that because if they hurt themselves, my people get fired. And it costs them a lot of money.
Sheriff, you're going to come up here so we get...
Sorry, I can't listen.
I think I speak for all the sheriffs. I know I do. I'm on the State and National Sheriff's Association. It is correct. Most jails house and quote-unquote treat. We don't treat. We house and we try to get them on medication. And then we try to give them a 2-week supply of medication when they leave.
With a very restricted formulary.
It has to be. Because I have inmates coming in and saying, I need this Valium at such and such rate at such and such. My doctor makes that decision, not theirs. But my job is to protect society from the criminal element. And when you've got, and I like what you said, 60%, when you've got those that are abusing drugs, which causes mental health, or they've got mental health and they're using prescription drugs because that's all that takes the pain away, quote unquote, they're going to commit crimes. And they're not just going to be misdemeanor trespassing, they're going to be felonies, they're going to be breaking into people's houses with axes. And then we don't have an innocent by reason of insanity in the state of Idaho. We have incapable to be able to stand trial, but we don't have an innocent, and so that does tie up the system. I think the jail is important as a net because some of these guys are extremely violent, and until that they can get on their medication or until they can get in their mindset that this needs to change, jail unfortunately is the only place. But we don't want to be a hospital. We are, but we don't want to be that. My people aren't trained to that. I try to train them, but I'm not required to do that. They don't teach that in post. I know you got me on the stand, so I'm gonna, I support 190% what's going on here. It's needed. Last night and this weekend, we've been chasing around a person that put on email. I know Dad's journal was something you wanted, sister. It's on my bed. To the rest of you, goodbye. 2 others in his family have already committed suicide, and we were following him by use of his credit card. He went all over the place. I put out ATLs and those type of things, extremely angry. And he did have a gun and a box of ammunition with him. Long story short, we were able to get him to the VA hospital on Monday when he did show up. It's my nephew. And I wasn't involved in it as sheriff of Bannock County. I was involved in it as Uncle Warren. We average a protective custody or assistance of suicide or depression a day. As long as I've been keeping soft statistics, a day. And I'll bet you Bonneville County isn't far behind us if they're not in front of us. Now they're averaging about 7 or 8, which I think is interesting. And I totally understand that when you take somebody, if I could have taken my nephew who was at a peak where he thought the only last thing he could do is kill himself, and we can take that and de-escalate it down, you bet. I'd rather have that, because that's what we're doing in jail. It just bothers me immensely, and I challenge you to come and spend a day. It bothers me immensely to be able to have those that should not be there, but for the fact of they are not taking their medicine, and when your brain is telling you don't have to take it anymore because you're feeling fine, you stop taking it, and then it takes a doctor to remind them they need to get back in. I know that we need this. I'll also be blunt. That doesn't mean we don't need a new jail facility.
We need a combined effort, Sheriff.
And I am totally in favor of, I'm on the board of directors for Hope and Change. I've also been signing on halfway houses. We've got a community that's trying to get there. Don't you think it's interesting that it's the law enforcement that is pushing this? Because we do know.
It's because we made you be the mental health professionals in the community.
Pardon?
It's because the society has made you be the mental health professionals in the community.
Exactly. I was talking to the sheriff of Clark County in Las Vegas, and he says we're the biggest and best mental health facility in the Southwest. I'm sorry, folks, that just ain't right. And we do have state hospital, and we do have others, but I'll also be blunt. It is a state issue. It should not necessarily be just one county doing great things and the surrounding counties not. They all get several that come up there I'm very familiar with. Paul and I are very good friends. How we're going to get it done, the devil's in the details. Sustainability is extremely important. And it is sad that it's the government that always has to be able to put this up, but when you take a look, how many new beds did the government put in to state hospitals? What, 5? Try to get clinicians to come up here and stay at Idaho's wages when they can go down to Utah, or they can go down to Colorado and get that type of, it's a big problem. You let me get on my book. As you can tell, I'm a little tender about it.
We have about 10 more minutes.
And so I'll shut up. But I was there on the other 2 kids when they killed themselves. I drove down. I helped clean the room up. I helped this kind of stuff. My friends, enough is enough.
Thank you.
That's all.
I have a question for Haley. Most everybody in this audience is intimately involved in these things. This is being televised, and it will be available on YouTube from the city. I would like for the people who are not professionals to hear from Haley some stories about who comes in, what do you do for them, and what is the result. Tell us what happens at your place.
Okay, so what I've been asked is to give maybe some success stories or some stories about clients that we've had come in. And as they've mentioned, I haven't been here long. I've been here almost a month, 2 months. And I have been amazed at what I have seen. One of the things that surprised me the most, we were talking with Tracy a little bit beforehand, is the relationship that clients are getting with law enforcement when they come in. I have heard countless times, and I've witnessed, when you come into our facility, it's kind of a weird building, and my office sits in the middle of what is like the living room, the lounge area, and I have a big window, so I get to see everybody all the time. And countless times I see these gentlemen. I have one in particular in mind that he was a true thug from Arizona. He had his gang tattoos all over his face and his head and his neck. Very scary looking man. He was there finishing up doing some social detox from methamphetamine. I was a little nervous, apprehensive to be around him. He looked pretty rough. And I look up in my window one afternoon and I see him and our law enforcement officer nose to nose having this conversation, and laughing and talking, and I can kind of hear enough through my door, not a whole lot, but I hear the gentleman say, every time I deal with cops, it's because I'm in trouble. I've never had an opportunity to sit down with law enforcement where I'm not being cuffed, I'm not being thrown in jail, I'm not being thrown to the ground, what have you. And he said, I am amazed at how cool you are. And my officer's like, yeah, you're cool too, bud. And they chit-chatted, shared some war stories for about 2 hours. And when the conversation ended, the client got up and gave the officer a hug. And he's like, I just want you to know that you've really changed my opinion on law enforcement, and you guys aren't as bad as I think you are, and you guys make this place safe. And that, it was really touching to me. I was telling my assistant, I wish I could take a picture right now. This is so cool. And that has been something that I never would have thought of coming in. There's a lot of talk with sustainability about pulling law enforcement out and bringing security agencies in. And I think that the law enforcement has been so vital in our center. And we hear it all the time. When we have clients leave, we ask them to complete a client satisfaction survey. Some do, some don't. And a lot of those are, law enforcement was so great. It was so nice to see a cop be nice to me. So that's something that I think is really special that I never would have realized, I never would have thought of. We also I've seen a few times, twice last week, in fact, people come in just to say thank you. I was in here 6 months ago. I was screwed up on drugs and alcohol. I was suicidal. You guys gave me this and this and this resource. Yeah, I had to go to jail for a couple of months, but I'm back and I'm out and I have a job and I want to show you a picture of my new wife and my kids. So we get that all the time, people coming in with the thank yous for what we have done for them. I do have, actually, I brought a couple letters that we've received from clients. On occasion, we get cards. We've had some flowers and stuff sent to us. So I have 2 clients that I documented their stories that they sent to us. One gentleman had said, I have utilized the Behavioral Health Crisis Center 3 times this month. Every time I have been met with open arms, ears, and an excellent caring for those in crisis. As I am learning to cope with my own demons, I realize how vital it is that this place is here. You are all so much an asset to this community that words simply do not do justice for the services you provide. And the second one said, she rambled for a while, and then she said, it is also very rewarding to see the change in attitude many of our clients have with regard to law enforcement, as they typically only deal with officers when they are in some sort of trouble. It was beautiful and inspiring to be able to interact with men of uniform in such a positive, helpful, and renewing way. This is a very informed establishment and an overall community wellness facility and tool. Thank you and God bless. So it's very rewarding to get to see those thank you stories. We do have a lot of people come in. We had this afternoon where they're so scared to come in. They're paranoid. They're afraid that they're going to end up in the hospital or they're going to be handcuffed. And we had a gentleman that sat in our parking lot for, I'm going to say, about 3 hours this afternoon. His recovery coach brought him to the parking lot. He agreed to get that far. And in the course of about 2.5 hours, individually, us workers went out and would chit-chat with him a little, offer him a cup of coffee, give him some space, come back in, and eventually he did come in. He had relapsed on methamphetamine, recently released out of state hospital, was afraid to go back to state hospital, saw the officer through the door, was scared to come in, and after just giving him some time and reassuring him that it was safe, that he wasn't going to be arrested, he wasn't going to be poked or prodded, he was able to come in, and we were able to admit him, and hopefully he'll be able to sleep it off and go back to his home. So we see a lot of good every day. Absolutely.
I can speak to one other. We have an amnesty box, and so the amnesty box is any individual coming in with drugs, paraphernalia, or anything, they can put their drugs in the amnesty box, no questions asked, no crimes charged. Okay, and so it's a safe place for those individuals that are high, that are using drugs on a regular basis. And so you speak about a success story. We had an individual spend about a year ago that was an IV heroin user. And she came in on 3 different occasions, dropped all of her drugs into the amnesty box, which pulled those drugs off the street, by the way. Put those drugs, put the needles, put them in the amnesty box to meet with our nurses to check her out medically, because she was worried about herself medically. She had some medical issues and some medical problems going on. And she had done that, I know of 3 times. It may have been even more. But she would come in every couple of weeks, drop off her drugs, and get the treatment and get back out. We've not seen her for a while. I don't know if she's got lost back in that world. I don't know if she found a level of sobriety. But for that time frame, when she had such a medical issue that she needed help and needed treatment, but could not kick that addiction, she was able to actually seek out and get some treatment. And every time she came in, it's like, hey, you shouldn't be doing drugs, you shouldn't be doing this, you shouldn't be doing the other. And same thing with her. Likewise, law enforcement, they take the drugs, drop them in the amnesty box, no charges filed. And so, was that a success case? I think it was for that time frame. How long of I don't know the ending to that story. It's probably not been written yet, but it was a very successful situation for this individual to receive that medical treatment. We talk about keeping them out of the ERs and saving those funds. We're able to do some of those kinds of things.
One of the things that I think that we see too, when you look at numbers and you talk about census, if we don't admit them, they're not counted as census. So we do have a lot of people that just come in to talk to our case managers or whatever. And we have a gentleman that comes in, he's got schizophrenia, and he's very psychotic most of the time. And he used to spend most of his life in and out of behavioral health center and state hospital. And since the crisis center has started, I believe he's only been hospitalized twice. I'm not positive, I think it's been twice. And he comes by almost every day, and he pops in and he checks our plants. He's got a love affair with our plants, and so he'll check on them, pull off the dead stuff, water them for us. And then he leaves, and he'll be fine. And then the next day he'll come in and he'll be not doing very well, and he may sit down with the psych tech and play solitaire for 5 minutes, and then he up and leaves again. And then maybe he'll come in and take a nap, and relax for a little bit, have a snack, and then he goes on his way again. And he tells us, and he always comes in to check with me to make sure it's okay that he's there, that it's just his safe place. He knows that he's not doing great in his mind. He still lives independently. And he says, if I can come in here and spend a couple hours, 20 minutes, then I can go home and I can be okay and I don't have to go to the hospital. And he always says, is that right? Is that right? I can do that. And that's the whole point. You don't have to be in some sort of crisis to where you need all these interventions and all these appointments scheduled and things that you have to do. You can come to just be safe and be quiet if that's all you need. And so I think we see a lot more of that than what numbers show, because they're not necessarily admitted.
So it looks like we have 2 questions.
Yeah.
Charlie?
One other question I wanted to kind of maybe follow up on the cost offset and certainly the partnership and all the money that we save in the hospital. First of all, my name is Charlie Austin. I'm the Director of Behavioral Health Services here at Portland Medical Center. I've been a psychiatric nurse for 35 years, and I've been facilitator, the Director of Inpatient Services across different areas for 28 years. So I know a little bit about the inflow and outflow of patients and inpatient and what they cost. And just straight out, like the sheriff, I absolutely totally support this operation. I've worked with Brenda up north, and certainly with you and Michelle and Tracy, all of you. So I'm very, very biased.
They can't hear you on the filming. You want to come up here?
Not really, but I will, right?
As I said, I've worked in this service for 35 years. So cost offset. Okay. Let's just take a look at what it costs to bring a patient in the hospital. Let's say it takes $1,000 a day. Maybe it takes $2,000. Maybe it takes $3,000. Robert, you and I have worked out contracts that came from the county that pays for those indigent services. Okay. Let's go back. What's that?
It's $1,000 a day.
Yes. Minimum.
I'm paying you more than that, Charlie.
Minimum. What's that?
I want the county's rate. I'm paying you more.
I know.
We're talking later.
Anyways, I said minimum. Okay? Depending on the payer source. There's a variety of payer sources.
They're better negotiators.
So,
Clearly.
you pointed out all the protective custody that's done. Sheriff, you know about protective custody. We also know protective custody sometimes is done for transportation outside of our county so that we can move that patient because we don't have room here or don't have the services. Okay? A lot of times we don't have the room here because we brought in patients who could be treated elsewhere. Cases where we don't need Demerol to treat a headache. We just need some aspirin. That's the aspirin. Okay? There's an old commercial that many of you may or may not remember. It's an oil commercial. Pay me now or pay me later. It's a mechanic with an oil filter. The hospital is a mechanic, and that's the oil filter. All of these variety of community services we have is the oil filter. That is what we're using to keep patients out of the hospital. Okay? That is one of the least expensive methods we can find. And it happens at the most vulnerable point of our patients' issues. Crisis. It happens at 2 in the morning. It happens at 3 in the morning. It happens at 4 o'clock in the afternoon. With who? With law enforcement. I don't want law enforcement sitting in my emergency room. They don't want to sit there. I spent the last 15 years trying to get them out of there. And I've gotten calls from your sheriffs saying, Charlie, come get me out of here. make this move faster. We don't have the rooms, we don't have somewhere where to put them, so they're sitting there waiting to transport someone, okay? Since then, now we've got contracts with Peak to transport patients. More money, more mechanics. So there's a lot of cost offset that can be done. So let's take a look at some numbers. Let's say that you save 2 patients from being hospitalized a week. That's rounded out to 100 a year, okay? Average stay at the hospital, let's go back some more. I admit about 800 patients a year to our inpatient services. They stay 5.7 days, okay? 2 patients a week, 100 a year, 570 days. Minimum cost, Robert, $1,000. $570,000, okay, that I don't get in revenue. Don't worry, I'll pick it up somewhere else. We're not running out of mental health issues. But what we're doing is we are not moving them in the proper spot. And we're treating them with what is not the least expensive and least restrictive opportunity that we have. And that's the opportunity that we're missing right now. We're not full across the board in all these other opportunities, but this one is a big blank hole. That overnight 23.59 stay that these patients need. They just need a little time. Sometimes it's 4 hours, sometimes it's 11, sometimes it's 23.59 hours, and they'll be back in 2 minutes. But it is the least expensive, it's the best bang for our buck, and it's the best thing for our patients and our community and those persons who are with illness. Okay. As far as saving the hospital money, you talk to any ER doc and you know it, Sean. They'd love to have this. They want to move those patients either out of their ED a little bit faster. I have a team in the emergency department. They're called Behavioral Health Assessment Team, BHAT, BHAT. They see 10 patients, 12 patients, 15 patients a day. And they're looking for disposition options for them because not all of them need to go into the inpatient unit. Some of them can just have a little hand-holding, little assessment, and we can move them home with their family. Others would need a little bit more professional help and a little bit more extension of our goodwill and our professional services. But you try to provide that in an emergency room, it costs a lot of money and a lot of time, and you're taking up a bed that somebody else could be using. So we need to have this disposition option. So, long time ago when I started working in healthcare, and we'd sit around and joking, nurses, that our job is to stomp out mental illness in our lifetime. Okay. Well, it's not happening. I'm not doing so well. Are we, Stephen? Not doing so well. Okay.
Our time's running out.
Okay. Anyways, this is one of the methods that we need to use for that. So, anyways, thank you.
Thanks, Charlie. Well, I'm sorry, but our time is over for the evening. I'd like to thank Michelle, Haley, and DeVere. Thank you for sharing information about the behavioral health crisis centers and how Idaho is trying to solve this problem that we have. I'd also like to thank Pocatello Community Media Channel 56 for televising the forum. It will be available for viewing on youtube.com/C/Pocatello Community Media. We hope this evening has enlightened you about behavioral health crisis centers and perhaps even sparked an interest in working to help get one established in our county. If you'd like to be further involved in this issue, please note on the sign-up sheet at the door, and we will make sure that someone gets a hold of you. And also we have league information available. Remember, the league is open to men and women, and we can keep you updated on our activities by liking us on Facebook, liking the League of Women Voters of Pocatello. And thank you again for attending this forum. Let's give them a hand.